Bismillahirrahmanirrahim. Assalamu alaikum. Today inshallah we will discuss another topic, that is the anterior abdominal wall muscles. In the previous lecture we have discussed the skin and the superficial fascia of the anterior abdominal wall. The superficial fascia had two layers. The superficial layer is named as the Kemper's fascia. This is fatty layer, and the deep membranous layer is named as Scarpa's fascia. Deep to the superficial fascia, we have 5 muscles which are anterior lateral abdominal wall muscles. Out of these 5 muscles, 3 are oblique and flat. They are external oblique muscle, internal oblique muscle, and the transversus abdominis muscle. Side by side we have 2 vertical muscles. One will be rectus abdominus muscle and one is pyramidalis muscle. Here in this diagram you can see the rectus abdominus muscle. This is rectus abdominus and this is pyramidalis muscle. This line which is in the median plane, this is named as linea alba. This is linea alba. The 3 flat oblique muscles, they come from the posterior lateral side and come anteriorly, and they are continued as the aponeurosis to reach the linea alba. These aponeurosis, they will decussate at the linea alba and they are crossed with the aponeurosis of the opposite side. See, this is an external oblique muscle. This muscle will end in the external oblique aponeurosis. This is internal oblique muscle fibers and this is the aponeurosis of the internal oblique muscle. Similarly, the transversus abdominis muscle will have the aponeurosis which will come near to the linea alba. These aponeuroses, which are of external oblique, internal oblique and the transversus abdominis muscle, they will form the rectus sheath. The rectus sheath is a covering of the rectus abdominis muscle which is covering the rectus abdominis from the anterior as well as the posterior side. And there is one pyramidalis muscle which may or may not be present. It is present on each side of the linea alba at the lower part of the abdominal wall. Now, what are the actions of the anterolateral abdominal wall? They form a firm but flexible wall that keeps the abdominal viscera within the abdominal cavity. They protect the viscera from injury and help in maintaining the position of viscera in the erect posture against the action of gravity. In addition, contraction of these muscles assist in both quiet and forced expiration. All these muscles, they are involved in increasing the intra-abdominal pressure during parturition, micturition and defecation. They are also moving the trunk. For example, the flexion of the trunk is brought about mainly by the rectus abdominis muscle. The lateral flexion of the trunk is done by one-sided contraction of the oblique muscle, and the rotation of the trunk is produced by the combined action of the external oblique with the opposite internal oblique muscle. See here in this diagram, these are the fibers of the external oblique muscle. When these fibers come anteriorly, it is transformed into an aponeurosis which is named as external oblique aponeurosis. Then deep to the external oblique, there is internal oblique muscle, and this will also end up into an internal oblique aponeurosis. And the third one, which is the deepest one, is the transversus abdominis muscle. This is transverse in direction, and this is the aponeurosis of the transversus abdominis muscle. These 3 aponeuroses, they will form the rectus sheath, which is a sheath covering the rectus abdominis muscle from anterior as well as the posterior side. And this is the linea alba, which is extending from the xiphoid process to the pubic symphysis. Now we will discuss each muscle one by one. First of all, the external oblique muscle. This is the superficial muscle of the 3 flat muscles. This is external oblique muscle. It is immediately deep to the superficial fascia. Its fibers, they pass in the inferior medial direction. See here, they are coming downwards and forwards and in medial direction. And they are approaching the midline, and the aponeurosis form the linea alba, which extends from the xiphoid process to the pubic symphysis. when the fibers of the external oblique muscle and they are forming the aponeurosis of the external oblique muscle, when they are coming down, they are thickening and forming one ligament which is named as inguinal ligament. See here, this is inguinal ligament. It is attached to the anterior superior iliac spine and the pubic tubercle. This is a ligament which is formed by the aponeurosis of the external oblique muscle when it thickens and folded on itself. Several other ligaments are also formed from the extension of the fibers at the medial end of the inguinal ligament. Number one is the lacunar ligament. This is a crescent shaped extension at the medial end of the inguinal ligament that passes backward to attach to the pectoral pubis on the superior ramus of the pubic bone. Additional fibers extend from the lacunar ligament along the pectoral pubis of the pelvic brim to form the pectennial ligament. See here in this diagram, this is the inguinal ligament and this is the lacunar ligament and this is the pectennial ligament, which is also called as Cooper's ligament. In this diagram also you can see the inguinal ligament. This is inguinal ligament, this is lacunar ligament and this is pectennial ligament. A triangular shaped defect in the external oblique aponeurosis lies immediately above and medial to the pubic tubercle. This is named as superficial inguinal ring. See here in this diagram, this is pubic tubercle. This is the external oblique aponeurosis. When this external oblique aponeurosis is coming down, here there will be one defect in the external oblique aponeurosis which is named as superficial inguinal ring. That superficial inguinal ring is immediately above and medial to the pubic tubercle. This is pubic tubercle and the superficial inguinal ring will be above and medial, and this superficial inguinal ring is formed by the aponeurosis of the external oblique muscle. From the superficial inguinal ring, the spermatic cord in males and the round ligament of uterus in females passes, and they carries the external spermatic fascia, which is the outer covering of the spermatic cord. This external spermatic fascia is the fascia which is the continuation of the external oblique muscle aponeurosis. So here we can discuss that there are three structures which are formed by the external oblique aponeurosis. Number one is the inguinal ligament, number two is the superficial inguinal ring, and number three is the external spermatic fascia. These three structures are formed by the external oblique aponeurosis. See here, this is inguinal ligament, this is anterior superior iliac spine, this is pubic tubercle. This inguinal ligament is bent back and form a crescent shaped ligament that is named as lacunar ligament, which is continuous posteriorly, and it is named as spectennial ligament or the Cooper ligament. This lacunar ligament is also called as Gimbernat ligament. External oblique muscle arises by 8 fleshy slips. See here, it will arise from the 8 fleshy slips from the outer surface of the middle of the shaft of the lower 8 ribs. See here, you can see the lower 8 ribs here. From the lower 8 ribs, from the middle of the shaft of those lower 8 ribs and from their outer surfaces, 8 fleshy slips will arise. This 8 is very important. The outer surface is very important. We have to remember that they are originating from the outer surface of the middle of the shaft. This middle is very important, and the lower 8 ribs. So there are many important points which you have to remember here. The fibers will run downwards, forwards and medially. This is the direction of the fibers of the external oblique muscle. When the external oblique muscle will comes downward, forward and medially, these fibers, they will end up in a broad aponeurosis through which they are inserted on the linea alba. From above downwards, first of all, they will insert over the xiphoid process and the linea alba and the pubic symphysis and the pubic crest and the pectineal line of the pubis. The lower fibers of the muscle, they are inserted directly into the anterior 2/3 of the outer lip of the iliac crest. These fibers, see here, these are the lower fibers of the external oblique muscle. They are directly inserting over the anterior 2/3 of the outer lip of the iliac crest, because there are two lips of the iliac crest. One is outer lip and the other one is the inner lip. So they are inserted over the outer lip of the iliac crest. Lower 6 thoracic nerves are supplying the external oblique muscle. They are T7 to T12. See here, these are the lower 8 ribs. The external oblique muscle is originating from the lower 8 ribs in the 8 slips. They are the 8 slips. Okay. They are coming downwards, forwards and medially, and they are inserted over the iliac crest. They are inserted over the pecten pubis and the xiphoid process and the linea alba and the pubic symphysis. So this is the insertion point. This is the insertion point and this is the origin. Again, you can see here the external oblique muscle is originating from the lower 8 ribs, from the outer surface of the middle of the shaft of the lower 8 ribs. The fibers are coming downwards and forwards and they are inserting over the xiphoid process and the linea alba and the pubic symphysis and the iliac crest. The outer surface, the anterior 2/3 of the outer lip of the iliac crest. Now we will discuss the internal oblique muscle. When we remove the external oblique, we can see the internal oblique muscle, which is the second of the 3 flat muscles. See here, this is also a flat muscle. This muscle is smaller and thinner than the external oblique muscle, with most of its muscle fibers passing in a superior medial direction. See here, the external oblique muscle was in the inferior medial direction and the internal oblique is in the superior medial direction. The lateral muscular component and in the aponeurosis anteriorly that blends with the linea alba at the midline. Similarly, just like the external oblique muscle and aponeurosis, here also there is internal oblique muscle fibers and aponeurosis, which is blending at the linea alba. Now the internal oblique muscle will originate from below. See here, it will originate from the lateral 2/3 of the inguinal ligament. This lateral and 2/3 is very important. It is also originating from the anterior 2/3 of the intermediate area of the iliac crest. Not from the outer lip, but it is originating from the intermediate area of the iliac crest. And it is also originating from the thoracolumbar fascia. The external oblique muscle was free posteriorly. It was not attached to the thoracolumbar fascia. See here, the external oblique will be free here, but the internal oblique muscle is attached to the thoracolumbar fascia posteriorly. From this origin, the fibers run upwards and forwards and in medial direction, crossing the fibers of the external oblique muscle at right angle. Because the external oblique muscles were coming downwards and forwards, the internal oblique muscles, they are fibers, they are going upwards and forwards and medially, so they are at right angle to one another. This is the origin. See here, again I will repeat, it is coming from the lower side and going upward. It is originating from the inguinal ligament, the lateral 2/3 of the inguinal ligament, the anterior 2/3 of the intermediate area of the iliac crest and the thoracolumbar fascia. From here the fibers will go upward and they are inserted over the lower 3 or 4 ribs, not 8 ribs, lower 3 or 4 ribs and their cartilages. The great part of the muscle and in the aponeurosis, through which it is inserted into the 7th and 8th and 9th costal cartilages, and it is inserted over the xiphoid process and the linea alba and the pubic crest and the pectineal line of the pubis. So it is coming from below and behind and going forwards and in front, and it is inserted over the xiphoid process and the linea alba and the pubic crest and the pecten pubis. It does not extend beyond the costal margin. See here, it will not extend beyond the costal margin. Lower 6 thoracic nerve and the first lumbar nerve, they are supplying the internal oblique muscle, that is the T7 to T12 and L1. Now, the aponeurosis of the external oblique, see here, this is the external oblique aponeurosis, and there are the aponeurosis of the internal oblique and aponeurosis of the transversus abdominis muscle. They will form the rectus sheath. This is the rectus sheath formation. Some aponeurosis will form the anterior wall and some will form the posterior wall. We will discuss the rectus sheath formation in the next lecture. Now, the internal oblique muscle, it also forms the conjoint tendon. Remember this thing, that conjoint tendon. In this diagram, you can see this is the internal oblique muscle and this is the transversus abdominis muscle. These two muscles, they will form one conjoint tendon. So, in exam, it can be asked that how the conjoint tendon is formed. The conjoint tendon can be formed by the internal oblique muscle and the transversus abdominis muscle. Along with this conjoint tendon, the internal oblique muscle is also forming the fibers of the Cremeester muscle. See here, this is the Cremeester muscle. It is also formed by the fibers of the internal oblique muscle. This is very obvious from this diagram. See here, this is the internal oblique muscle. It is originating from the thoracolumbar fascia, the iliac crest, the intermediate area of the iliac crest, and the lateral 2/3 of the inguinal ligament. The fibers are going upwards and medially, and they are inserted over the lower 3 or 4 ribs on the xiphoid process, on the linea alba, and the pubic symphysis. Now we will discuss the transversus abdominis muscle. It is a thin sheet of muscle that lies deep to the internal oblique. That is, when we have to remove the internal oblique muscle, only then we can see the transversus abdominis muscle. It has an anterior aponeurosis which blends to the opposite aponeurosis of the transversus abdominis muscle at the linea alba. The lowest tendinous fibers, as we have discussed before, that the lowest tendinous fibers of the transversus abdominis muscle and the internal oblique muscle, they will form the conjoint tendon. The conjoint tendon is attached to the pubic crest and the pectineal line. The transversus abdominis muscle has a fleshy origin. It originates from the lateral 1/3, not the 2/3, because the internal oblique was originating from lateral 2/3 and this transversus abdominis is originating from the lateral 1/3 of the inguinal ligament. It is originating from the anterior 2/3 of the inner lip of the iliac crest. That is, the iliac crest has an outer lip, the intermediate area, and the inner lip. So from the outer lip, the external oblique muscle is attached to the intermediate area, the internal oblique muscle is originating, and to the inner lip of the iliac crest, the transversus abdominis muscle is originating. So this is the inner lip of the iliac crest. Then the thoracolumbar fascia and the inner surfaces of the lower 6 costal cartilages. They are originating from all these structures. Then the fibers are directed horizontally forward. The fibers end in a broad aponeurosis which is inserted into the xiphoid process and the linea alba and the pubic crest and the pectineal line of the pubis. Again, it is revised that the conjoint tendon is formed by the lower fibers of the internal oblique and the lower fibers of the transversus abdominis muscle. Same is the nerve supply, the lower 6 thoracic nerves and the first lumbar nerve, that is T7 to T12 and L1. You can see here the transversus abdominis muscle. This is transversus abdominis muscle. Okay, it is originating from the inguinal ligament. See here, this is the lateral 1/3 of the inguinal ligament, the inner lip of the iliac crest, anterior 2/3 of the inner lip of the iliac crest, then the thoracolumbar fascia, and then the lower 3 or 4 ribs, and then the fibers are passing transversely. See here, this is in transverse direction. It is transformed into the aponeurosis which is inserted over the xiphoid process and the linea alba and the pubic symphysis and the pecten pubis. It also forms the rectus sheath. In the rectus sheath lecture, we will discuss that how the rectus sheath is formed. See here in this diagram that this is the external oblique muscle. Then this one, the brown colored, this is internal oblique muscle, and this one is the transversus abdominis muscle. Here you can see that the neurovascular bundle is present in between the internal oblique and the transversus abdominis muscle. So this is the neurovascular plane. The aponeuroses of the three flat muscles, they seem to end in a fibrous raphe, that is the linea alba. This is the linea alba. Each aponeurosis is made up of two lamina. See here, the external oblique aponeurosis can be divided into two lamina. The internal oblique aponeurosis is divided into two lamina, and the transversus abdominis aponeurosis is also divided into two lamina. See here, this is the formation of rectus sheath. The external oblique aponeurosis and one lamina of the internal oblique aponeurosis will pass anteriorly and form the anterior wall of the rectus sheath. And the transversus abdominis aponeurosis and the posterior lamina of the internal oblique aponeurosis will pass posteriorly and form the posterior wall of the rectus sheath. So all three aponeuroses will contribute in the formation of rectus sheath anteriorly and posteriorly. Now we will discuss the rectus abdominis muscle. See here, this is a long strap muscle that extends along the whole length of the anterior abdominal wall. It is broader above and lies close to the midline, being separated from its fellow by the linea alba. See here, this is linea alba, this is right-sided rectus abdominis, and this is left-sided rectus abdominis. You can see the tendinous intersections which are present in the upper part of the rectus abdominis muscle. One intersection is present at the level of umbilicus, one is present at the level of xiphoid process, and this is the xiphoid process. This intersection is present at this level, and there is one intersection which is present midway between the xiphoid process and the umbilicus. This area or these tendinous intersections will divide this muscle into 6 packs. These are the 6 packs which are very prominent in a people who do exercise. See here, this is linea alba, and there is a one line which is lateral to the linea alba. It is named as linea semilunaris. This linea semilunaris is showing the lateral margin of the rectus abdominis muscle. This is a half moon shaped line which is from the 9th costal cartilage to the pubic tubercle. It will go below and it will be inserted, or it will finish at the pubic tubercle. This is from 9th costal cartilage to the pubic tubercle. This is linea semilunaris. This is showing the lateral border of the rectus abdominis muscle. See here in this diagram, these are the tendinous intersections, one at the level of umbilicus, one at the level of xiphoid process, and one between the two. So what is the origin of the rectus abdominis muscle? There are two heads of the rectus abdominis. See here, this is the medial head and this is the lateral head. The medial head will originate from the medial part of the pubic crest, and the lateral head will originate from the lateral part of the pubic crest. So it will originate from below and it will go or run vertically upward, and it is inserted over the xiphoid process and the 7th and 6th and 5th costal cartilage. See here, it is over the 7th and 6th and 5th costal cartilages. So this is one vertical strap muscle which is going from below and running upward and inserted over the xiphoid process and the 5th, 6th and 7th costal cartilages. The lower 6th or 7th thoracic nerves will supply the rectus abdominis muscle. See here in this diagram, this is the medial head of the rectus abdominis and this is the lateral head, and this is the pubic crest. This is the medial part of the pubic crest and this is the lateral part of the pubic crest. So it will go upward and it is inserted over the 5th and the 6th and the 7th costal cartilage and the xiphoid process. These are the three tendinous intersections, one at the level of the xiphoid process, one at the level of the umbilicus, and one between the two. Now we will discuss another muscle, which is Cremeester muscle. See here, Cremeester muscle is embedded in a cremastatic fascia. This is the second fascia, or this is the fascia which is deep to the external spermatic fascia. As we have discussed before, that the external spermatic fascia is formed by the external oblique aponeurosis, and this is the second fascia which is deep to the external spermatic fascia, and so this fascia will be formed by the internal oblique aponeurosis. So this is cremastatic fascia. It will enclose one muscle, that is the Cremeester muscle. The medial end of the loops, they are in the form of loops, and the medial end of the loops, they are attached to the pubic tubercle and the pubic crest and the conjoint tendon. This Cremeester muscle, it is fully developed in males. In females, it is represented by few fibers only. The genital branch of the genitofemoral nerve L1, this is very important. It is supplying the Cremeester muscle. In exam, it is asked that what nerve or which nerve is supplying the Cremeester muscle. It is the genital branch of the genitofemoral nerve, and the root value is L1. What is the action of Cremeester muscle? The Cremeester muscle helps to suspend the testes and can elevate it. See here, it can elevate the testes also. The muscle also tend to close the superficial inguinal ring when the intra-abdominal pressure is raised. So it will protect the inguinal canal. It will protect the inguinal canal from the hernia, or prevent the hernia to occur. Premastatic reflex. What is premastatic reflex? It is a reflex which is used, or which is done to check the innervation of the Cremeester muscle, that is the genital branch of the genitofemoral nerve, that is the L1. So if we want to check that whether the L1 or the genital branch of the genitofemoral nerve is working or not, what we will do, we will stroke the skin of the upper side of the medial side of the thigh. Here we will stroke the skin. There will be reflex contraction of the Cremeester muscle, as evidenced by the elevation of the testes and the retraction of the testes. This reflex is very brisker in children. In upper motor neuron lesion, this reflex is lost due to L1. Now we will discuss the pyramidalis muscle. This is the fifth muscle which we have to discuss. It is a rudimentary, small, triangular muscle that lies in front of the lower part of the rectus abdominis muscle. It is often absent. It arises from the anterior surface of the body of the pubis. Its fibers pass upwards and medially to be inserted into the linea alba. This muscle is supplied by the subcostal nerve, which is the 12th thoracic nerve, T12. This question can also come in your exam, that with which nerve the pyramidalis is supplied and what is the root value of that nerve. So this is the subcostal nerve or 12th thoracic nerve. This is the muscle which is making the linea alba tense, but its action is not clear. Now, what is inguinal ligament? The inguinal ligament, which is also called as the Puppert's ligament, it is formed by the lower border of the external oblique aponeurosis. This question is very important. It can come in the multiple choice question also, that how the inguinal ligament is formed. It is formed by the external oblique aponeurosis when it is thickened and folded backward on itself. What is the attachment of the inguinal ligament? It is attached to the anterior superior iliac spine to the pubic tubercle. This is the extent, and it lies beneath the fold of groin. Its lateral half is rounded and oblique. Its medial half is grooved upward and is more horizontal. Attachments: the fascia lata, which is the deep fascia of the thigh, is attached to the lower border of the inguinal ligament. Traction of this fascia makes the ligament convex downward. The upper surface of the ligament gives origin to the internal oblique from its lateral 2/3 and the transversus abdominis from the lateral 1/3 and to the Cremeester muscle from its middle part. You can see here, this is anterior superior iliac spine, this is pubic tubercle, this is the inguinal ligament which is formed by the external oblique aponeurosis. These are the lacunar ligament fibers which are continued as the pectineal ligament. This is pectineal ligament. This is the reflected part of the inguinal ligament. See here, these are the fibers or reflected fibers of the inguinal ligament. They are crossing on the opposite side and decussating with the fibers of the opposite external oblique aponeurosis. aponeurosis. There are some intercrural fibers also. This is the superficial inguinal ring, which is again formed by the external oblique aponeurosis. It is above and medial to the pubic tubercle. This is pubic tubercle. This is above and medial to the pubic tubercle. Again, you can see here, this is the skin. Outside there is the skin, then there will be superficial fascia here, and then the external oblique aponeurosis. This is external oblique aponeurosis. In this aponeurosis, one defect is present which is named as superficial inguinal ring. Then there is the internal oblique muscle and internal oblique aponeurosis. Then there is the transversus abdominis muscle and the transversalis fascia. See here, this is the transversalis fascia which is present here. These are the three coverings of the abdominal wall. This external oblique muscle will be continued as the external spermatic fascia in the spermatic cord and the scrotum, and this is internal oblique muscle and aponeurosis will be continued as the Cremeester fascia in the spermatic cord and the scrotum, and the transversalis fascia will be continued as the internal spermatic fascia of the spermatic cord and the scrotum. The superficial inguinal ring is a triangular defect in the external oblique aponeurosis, and there is one defect in the fascia transversalis. See here, this is the fascia transversalis, and this is a defect which is present here, which is named as deep inguinal ring. This is also named as internal inguinal ring. The superficial inguinal ring is the external one and deep is the internal one. The superficial is in the external oblique aponeurosis, the deep is in the fascia transversalis, and the area or the path which is between the deep inguinal ring and the superficial inguinal ring is the inguinal canal, and the spermatic cord is passing from the deep inguinal ring to the inguinal canal, passing through the superficial inguinal ring and coming inside the scrotum. Again, you can see skin and the superficial fascia, then the muscles, the external oblique muscle and aponeurosis, which is continued as the external spermatic fascia, then the internal oblique muscle and aponeurosis, which will be continued as the Cremeester fascia, and the fascia transversalis will be continued as the internal spermatic fascia. These are the charts which I have pasted for the origin, insertion, nerve supply and function of the abdominal wall muscles. I have pasted many charts from all books which you can get access. Now the direction of the fibers. As we know that the external oblique muscles, they are going downwards and forwards. The internal oblique muscles, they are going upwards and forwards. And the transversus abdominis muscle is in the transverse direction. The posterior border of the external oblique muscle is free, whereas the internal oblique muscle and the transversus abdominis muscle, they are attached to the lumbar vertebra by the lumbar fascia. This is the lumbar fascia. This is also the lumbar fascia. Here there is no attachment with the lumbar fascia. Now, deep nerves. The anterior abdominal wall is supplied by the same nerves which were supplying the superficial area or the skin and the superficial fascia and all muscles. So these are the same nerves, T7, T8, T9, T10, T11 and T12, which is the subcostal nerve, and L1, that is having two branches here, ilioinguinal nerve and iliohypogastric nerve. These are the nerves that emerge as the cutaneous nerve. These are the same nerves which are present between the internal oblique and the transversus abdominis muscle, and these nerves will emerge on the skin and the superficial fascia as the cutaneous nerves. Now we will discuss the arteries. There are two large arteries from above, that is the superior epigastric artery and the musculophrenic artery. See here, these are the branches of the internal thoracic artery. This is internal thoracic. It is giving the superior epigastric and musculophrenic. There are two large arteries from below. One is inferior epigastric. See here, this is the inferior epigastric, and there is deep circumflex iliac vessel. This is the deep circumflex iliac vessel. So they are coming from the external iliac artery. Small branches which are subcostal arteries and lumbar arteries will be present here. See here, this is the superior epigastric artery and this is the inferior epigastric artery. Then these are the lumbar arteries which are present, intercostal arteries which are also present. There is a deep circumflex iliac vessel which is also present here.